So next up as moderator is Dr. Rizwan. He's going to be talking about the mangled extremity with his esteemed group of surgeons. So Dr. Rizwan, it's all yours.
Thank you, sir. Thank you, Dr. Selene. Can you hear me?
Yes, we can.
Okay. So, good morning from Pakistan. This is Dr. Rizwan Haroon. Today with me, I have got Dr. Sohail Muzammil. He's currently working in Doctors Hospital, Lahore. Dr. Tashfeen Ahmad, who is another of our faculty, working at Aga Khan University Hospital, and also Dr. Tashfeen Ahmad, who is working at Aga Khan University Hospital, Dr. Haroon Rashid, who is also working at Aga Khan University Hospital. So we will be starting the talk with the mangled extremity. I will like Dr. Sohail. Can you please start?
So guys, we're going to be talking about the mangled extremity. And the situation is that there's very few classifications that we know of. And that's what confuses the thing somewhat. Now, most people will say that we know a mangled extremity when we see one. But for purposes of definition, the mangled extremity would be defined by a lot of people as if they've got 4 systems, 3 systems are damaged, like soft tissues, bones, vessels, and nerves. One is left, and 3 are damaged. But again, as I said, most people will say they can tell damaged, mangled extremity when they see one. So, but one thing we know for sure is that the patient's leg, as they know it, has gone. And once amputation is brought up, the patient's reasoning sort of is, it goes out the window. The patient is in such a situation that you cannot sort of reason with him or even make him understand. Now, the patient will ask you, their question is going to be, can you save my leg? And mostly you'd be asked, what would you do in my place? And that's putting you on the spot, kind of, because nobody knows, or rather knew until very recently with any evidence what is going to happen. And given the lack of evidence, Hansen, in his editorial in 1987 in the JBJS, went on to suggest that the salvage is futile. It would be a disservice to patients, and in an effort to save the limb, we may go ahead and ruin his life. However, he also mentioned that it would be a good idea to have a study or a prospective trial on this and see if we can get some better evidence to guide our judgment. So that's precisely what happened in the LEAP study. And this was a prospective trial. We'll be talking about this in detail. But the outcomes that came out of this were rather surprising at the time. That with reconstruction, typically at 2 years, these patients did the same as amputation, or patients who had amputation. However, they noted that reconstruction is associated with a higher risk of complications and additional surgeries and rehospitalization. Now let's look at this LEAP study. That was the or that is the best evidence that we have for managing the mangled extremity today. So the LEAP study was NIH funded and was done in 8 level 1 trauma centers in the United States with 601 patients. And it was a prospective trial, which was the first for this sort of, for the mangled extremity. And the trauma that was considered was lower limb from the distal femur onwards. And the great thing about this study was that at 7 years, almost a very large majority of patients were followed up. So this is the best evidence that we have until today. So let's see what the LEAP study tells us. Now, this, as I said, this prospective study is the best evidence that we have. And the important thing that they did in this study, because it was prospective, apart from age, sex, and comorbids that are usually noted and taken into account, patients' values, beliefs, their psychological profiles, their addresses, physical surroundings, their educational level, economic background, and social and work conditions all were taken into consideration and noted. The other thing was that there was no control group and there were no treatment protocols per se. So all the treatment or management was left to the treating surgeons. So the outcome was measured by the sickness impact profile, which is the SIP. And this was the sort of structure of the study. Now, moving on. So the patient population was, they were mostly white male, 20 to 45 years of age. They were of a lower socioeconomic background and were less educated than the majority or than the population, were more likely to be uninsured and twice as likely to be heavy drinkers. So this was the sort of population, the young and the restless sort of group. And as we know that trauma is a disease of poor people, and here we see that poor young white people with a lot of what we would say less education and very and psychologically they were more likely to be impulsive, less likely to be receptive to new ideas or suggestions. So if you can see the results and the SIP scores, yeah, there was no difference in the results between amputation and salvage at 2 years. However, 4% of the salvage group went on to amputation at the end of 2 years, and both groups were scoring lower on the SIP score at 7 years follow-up. So gradually the results deteriorated. For poor outcomes, the main sort of pointers for poor outcomes were a non-white race, rehospitalization for major complications, lower self-efficacy, a lower educational level, poor social support, poverty, lack of insurance, smokers, and especially those who were involved in some sort of litigation. So that was the sort of group that did poorer in the SIP scores. So as far as the management versus the outcomes, we saw that BKA or below knee amputation and above knee amputation yielded similar SIP scores in the amputation group. However, through knee amputations were the ones who did worse in the end. And surprisingly, sophisticated prostheses did not improve the outcomes. So simple prostheses were the same as very sophisticated prostheses. So, and the other important thing was that the injury severity scores or indexes, they did not predict whether this limb would go on to salvage or amputation, and neither were they useful in predicting outcomes. So none of the predictive scores like the MES were useful in predicting anything. So, and the other surprising thing that came out was that insensate plantar skin is not an indication for amputation and was not a predictor of outcome even, because most of these patients who with insensate plantar skin who were later followed up, they regained plantar sensation. So that's one of the surprising things. Now, can you see the management versus? Can you see the next slide, please, or can you bring on the next slide?
Yes.
So again, as far as the timing was concerned, timing of surgery, neither debridement, if it was carried out at less than 6 hours or even up to 24 hours, made any difference. Soft tissue coverage, if it was delayed beyond 72 hours, again, this is counter to the recommendations that we have. Again, there was no difference. And bone grafting less than 3 months or more than 3 months, again, no difference in outcomes. In Again, free flaps or rotational flaps. There were no differences in outcomes except in the group that had the severe type C fractures, which probably implied a higher soft tissue injury, a greater zone of injury, and therefore local rotation did not do well. Could you move on, please? And of course, nailing yielded better outcome than external fixators, and this is probably because lesser severity of injury allowed nailing to be done, and so therefore this is probably a severity bias. Moving on, please. So patient satisfaction was ultimately seen in patients who were able to function better, had better pain relief, were not depressed, and were able to return to work. Surprisingly, next please. Surprisingly, the injury or the treatment choice did not determine outcome or was not a primary driver of satisfaction of the patient. Moving on, please. So costs were calculated, and at 2 years, surprisingly, amputation cost more than reconstruction, and that was probably because of the prosthesis costs. And similarly, projected lifetime costs of reconstruction were way less than amputation, again because of the projected costs of the prosthesis. And we'll be talking about this in a moment. So it appears that amputation costs more. Moving on, please. So what about chronic pain and disability? Half of the patients in both groups were severely disabled with a SIP score of greater than or equal to 10. One-third of the population scored no excess disability, and the usual suspects in disability or the patients with a higher, who showed a higher level of disability were again poorer people, lesser educated, non-Caucasian, and those who were involved in litigation, and we've discussed those. So these were the same predictors of a higher level of disability. In reconstruction, in limbs that were reconstructed, extensive soft tissue injury without fracture, they had a higher level of disability. And in amputations, as we discussed through knee amputations, these patients had a higher level of disability. Could you move on, please? So about pain, 23% were pain-free at the end under follow-up, and the rest of the cohort recorded similar results as in a population of chronic back pain. So could you move on, please? At 7 years follow-up, and we can see a large number was followed up at 7 years. 423 of these patients returned to work. And there was no statistical difference between the groups. So amputation or reconstruction, both were similar group return to work. However, at work, a 20 to 25% impairment was seen. So the factors that determined a return to work were mainly pain and function at 3 months. And these were mainly in or more of this group went to work, which were white, young, educated, had a higher self-efficacy or a higher confidence in their capability of handling things, and had pre-existing employment tenure and were non-smokers. So these were the ones who did better on return to work. But again, no difference between the two groups, amputation or reconstruction. Could you move on, please? And both groups did better physically and functionally with physiotherapy. Now, I would just like to invite my panelists in contributing. Do they see the same sort of results? Because this is the largest prospective study that we've seen. So, Dr. Rizwan, Dr. Haroon, do you see a similar sort of outcome in your group of patients?
Yeah, Dr. Sohail, absolutely. We see the similar outcomes.
Sorry?
Basically, sometimes amputees does better. Anything you want to say, Dr. Haroon?
Yeah, okay, Dr. Rizwan. First of all, I must congratulate Brigadier Muzammil for his brilliant
Dr. Haroon, Dr. Sohail has asked a question. Dr. Sohail, can you repeat, please?
Yes, my question was that can you hear me?
Yes.
Yeah, sure.
All right. My question was that you've seen this, the results of the LEAP study, and this is probably the best prospective trial in mangled extremity, lower extremity rather. So, do you see similar outcomes as were seen in this study, or do you see similar results? What do you have to say about these results in our sort of situation?
Thank you very much for your brilliant presentation. Rizwan, do you hear me?
Yes, I can hear you. Can you answer Dr. Sohail's question?
Yeah, sure. So, first of all, very brilliant presentation, and thank you very much for presenting this. So, in our setup, we do not have a lot of volume, larger volume to make any conclusion, but certainly there are differences like cultural differences, educational differences, which certainly affects the patient understanding and outcome. So, yeah, the best day to decide salvage or amputation is the day one in emergency room. So in our setup, it is if you salvage a non-functional extremity, so it becomes very difficult to convince them to offer amputation later on. So if the decision and patient understanding, educational level are okay, so we do have salvage with good outcome.
So, Dr. Sohail, can you please wind it up? We have got interesting cases for
Yeah, if we
discussion.
could just move on to the next slide.
Yeah.
So as you mentioned, the relevance in our part of the world. Now, the authors themselves did give this reservation that this was a study in level 1 trauma centers. Not all people that we see are, or not all of us work in level 1 trauma centers, and we don't have the resources of a level 1 trauma center. And so, do we have the can we afford? Can our patient population rather afford the expenses of these state-of-the-art interventions required for limb salvage? And we don't. Again, in this study, these patients turned up straight to the trauma center within 24 hours. We see a lot of morbidity when with ill-advised surgical adventures before the patient reaches us. So again, that's a problem. And about costs. Now, we know that here in Pakistan, at least, and in the third world, prostheses are not very expensive. So, and healthcare is quite expensive. So, I believe that the costs that we see, or the equivalence of costs that we see in the LEAP study, is not applicable to Pakistan or probably even to India or Africa, because prostheses cost not a lot. Even a lot of them are supplied by charities. So that is something we need to look at. And our demographic predisposes to poor outcomes, because trauma is a disease of poor people. And this is what they are the ones who are going to get these injuries. And we know from this study also, have poorer outcomes and lower self-efficacy. So to wind up, and in conclusion, last slide, please. So, given appropriate resources and under ideal circumstances, reconstruction and amputation have similar outcomes over the medium and long term. Reconstruction costs less in the long term in the West, probably not exactly here. Reconstruction is more likely, although the outcomes are similar, but more likely to require rehospitalization, reoperation, and have a higher incidence of osteomyelitis. And we know that outcomes in both groups are similar. And mostly these outcomes are determined by psychosocial factors more than any mode of treatment or the injury. And self-efficacy, the confidence of the patient of handling their own situation, is the highest sort of prognostic factor. So thank you very much, gentlemen. I'm sorry for the glitches that we had in this presentation.
Thank you, Dr. Sohail. Sorry again to the audience for the glitches. Now we have Dr. Tashfeen with an interesting case which he managed. So, Dr. Tashfeen, due to the time wasted, you are requested to kindly finish within 10 minutes.
All right. All right. Am I audible?
Yes, you are audible and I can see your slides.
Great. Bismillahirrahmanirrahim. Hello, everyone. Thank you for attending this session. I work at the Khan University in Karachi, Pakistan. So I have nothing to declare. So this is a 45-year-old gentleman who was an aircraft engineer, and he presented with a history of crush injury to both feet while working on the airport tarmac. When you talk about crush injuries, I think it would be interesting to know that he was run over by a tire, and the tire happened to belong to an aircraft. And aircraft was not really as small as this one, which I am showing here. The actual aircraft was a McDonnell Douglas DC-10. Now that's the size of the aircraft. And it was a nose wheel which ran over his foot. The tire itself weighs 180 kg, and the aircraft, when it's fully loaded, weighs about 260 tons. So that's the amount of injury which he suffered to both of his feet. So the left foot, I'll start with the left foot first because the injuries were very different in both feet. That is why I'll take one foot at a time. So the left foot had degloving injury involving the whole foot. Apologies for the gory appearance of the pictures, but that's what the foot looked like. Complete degloving. The skin was just hanging on the foot, and we just by pulling it, we took it off. So that's how the skin was. So in terms of skeletal injuries, there was some injury to the big toe, distal phalanx, and the metatarsophalangeal joint. But otherwise, the rest of the skeleton seemed to be okay on the X-ray. For brevity, I'm not showing all of the X-rays. So what was done was that the plastic surgeon tried to defat the skin, and he put it back. The skin seemed to be surviving partly, but eventually all of the skin got necrosed. So then it was managed by during this period it was managed by vacuum dressings, and eventually he required skin grafting of the whole of the foot. So so he was about 2 months or so after the injury, he was allowed to start working on it, and the foot survived with the grafted skin all over the foot, including the plantar aspect. He had no sensation initially, but later on has developed progressive sensation. So these are 4-year follow-up X-rays which show pretty good foot, except for the big toe, and that is not problematic for him at all. So he has been ambulating, full weight bearing on this foot. He has occasional scar breakdown at pressure points, but otherwise he's happy. So the conclusion is that despite extensive soft tissue loss, foot injuries may heal well and permit good function. That's the takeaway from this particular case. Now for the other foot, I'm missing the immediate emergency pictures, but these are the ones that were that I had after our initial procedure. He had extensive degloving from the medial aspect of the distal tibia and the ankle, including the heel. The heel pad was gone. There was gross contamination. Tendons were exposed. Plantar fascia was exposed. There was rupture of the extensor tendons, tibialis anterior. Pulses were weak. Perfusion was poor in the toes, but it was not absent. Now, we discussed with the patient that this appears like a unsalvageable foot, but he was saying that we should try to salvage it. On the X-rays, we can see that there is a talonavicular dislocation. There is a comminuted fracture of the cuboid. The arch is lost, the calcaneal pitch is lost, and there's a fracture of the talus neck. So it's basically a Hawkins 4. The rest of the forefoot did not have any significant injuries. Midfoot, forefoot did not have any significant injuries, skeletal injuries, apparently from these X-rays, right? So here's a close-up. We can see the fractures more better here. Now, by the way, this what looks like the talar head is actually not the talar head. That's the navicular, because there's a cuneiform adjacent to it. The navicular is dislocated medially, and the head is behind it. In fact, you see a shadow near the sustentaculum tali, and that round shadow is actually the rotated head of the. I don't know. I can't point from using this one. This is the tail head of the talus. So we gave a guarded prognosis, and the findings I've already explained. So initially we did a temporary external fixation, K-wire fixation of the talar neck, and that's what the appearance looked like. We did not have any pin in the calcaneus. This was an old case, and if I was to do it now, I would definitely put a pin in the calcaneus. But this was a temporizing measure because he wanted to have reconstruction of the foot. So the talus neck was fixed, the navicular was fixed with it to the head. He developed gross wound infection despite debridement and antibiotics. And about a month after the injury, when the wound had settled and infection had settled, then we performed internal fixation and reattached the tibialis anterior. The ankle was also stabilized using a retrograde 25 2.5 millimeter K-wire, and the X-fix was left in the position for a further month. And that's on the picture on the right is the one after removal of the external fixator, and we see that the arch is pretty reasonable. The talonavicular alignment seems acceptable, I would say. Not perfect. There was a lot of comminution there, but that's what we were able to achieve. So wound required coverage, and a latissimus dorsi flea flap was done by the plastic surgeon. But there was again infection following that, and the flap eventually necrosed and had to be excised. So vacuum dressings were done, and eventually thickness skin grafting was done. So we had, this is about 4 months post internal fixation. That's the period that we removed the wire and allowed him to start walking. It seems like the arch is okay. But in the follow-up visits, we found that clinically the arch was progressively getting lost. The foot drop, despite our reattachment of the tibialis anterior, the foot drop evolved. The midfoot was collapsing on the X-ray, and there was disruption of the internal fixation, including the talar neck. So what this all indicated to me was that none of the ligaments and the bone had healed. None. So the skin, the loss is only one part of the total injuries which he had. It was a microcirculation loss due to the severity of the crush injury, which probably devascularized all the bones and all the ligaments, and leaving no potential for them to heal. Even though there was perfusion in the toes, uh, the perfusion in the middle segment due to the crushing was probably completely gone. So nothing had healed, as you see on this X-ray. And many of the ligaments which we had not recognized initially, uh, they had also not healed. Although the foot was very floppy right from the beginning, we knew there was extensive ligament injury. But despite 4 months of stability, nothing had healed. We started weight bearing after 4 months, and it completely collapsed. We offered an amputation. The other options was multiple midfoot arthrodesis, tibialis anterior repair or reconstruction with grafting, or erasure of using closed methods. But knowing that the vascularity was really unpredictable, in that area. We told him that there would still be a high chance of failure if we attempt to salvage it. Eventually, he opted for amputation. He sought opinions, including from overseas, and eventually went for amputation. So that's the take home from this case, that despite management of the skin and other soft tissues, the skeletal injuries themselves may not heal well in severe crushing injuries. I tried to look at the internet. There was other case of runover injury reported in Pakistan, but that person died. He had multiple other injuries. Um Foot injury. There was a report from Gatwick, which I found on the news media, but not on PubMed, where a was run over by a Russian airplane. Couldn't get any further details of that particular case. So this is I would say, a rare case with a very massive force which has crushed the foot. One of them, because the patient, when the left foot was caught under the tire, he forcefully tried to pull it out and managed to get his foot out minus the skin. And when he did that, he tried to get out of the way of the aeroplane. There was some miscommunication between the pilot and the driver of the tug which pulls the aeroplane, and the tug's driver started moving the aeroplane, assuming that he got a go ahead for moving, while the actual intention of the captain was not to start immediately. So when this my patient tried to get up, he again fell, and his other foot landed in the way of the aeroplane, and that's how that got extensively crushed. Just the latest information. The actual airplane was not a DC-10. I talked to him yesterday, and it was a Airbus A330, which is slightly larger than a DC-10. I didn't get the time to change the picture.
Thank you,
So
Dr.
that's all
Tashfeen,
from me.
for
Thank
an
you.
interesting case. Dr. Sohail, a small opinion. How would you have managed this case? Then we will move on to Dr. Haroon, who has got interesting cases. So kindly a small 1 minute talk about how would you have managed this case, or you would agree to what Dr. Tashfeen did for his management.
All right. Basically, given that his foot had become a big sock, and so very hard to replant that. But I think one would always, with all of the foot intact, one would like to try and salvage whatever you could. However, I would say that in the end, what I would do, what Dr. Tashfeen did, try to save the foot, and obviously counseling the patient as he did, that amputation was a probable outcome, and they are doing all, or we are doing all we can do to try and save the foot. However, these things happen, we know, under the best of circumstances.
Thank you. Now we will be moving forward to Dr. Haroon Rashid's presentation. Dr. Haroon.
So first of all, thank you very much, Rizwan, for giving me an opportunity to present roundup of few cases managed. Just a brief history. This was a young man. Our encounter was in the earthquake mission in 2005. So this young man has some ankle trauma in a remote northern area of Pakistan. Certainly, you can judge from the X-ray that even the basic facilities for health care was not available in his area. So no attempt was made to reduce his ankle. He presented to us in 2 weeks' time with this ankle still dislocated, fracture dislocation, as well as a big skin defect on the medial side over the medial malleolus. There was a discussion between him and us about salvage, duration of treatment, and versus amputation. So he did agree about salvage, but did not agree about any lengthening of the shortened extremity, which would have resulted from resection of this dead visible bone. So before my arrival there, one of my colleagues who was the team who was already there tried to reduce without bone resection and applied this circular external fixator and tried to close the wound with the help of this rubber band. But sooner, though there was no infection, but his skin breakdown and result was a bigger defect than he came to us. So yeah, then this patient was handed over to us. So at our center, so most of the skeletal injuries as well as soft tissue part are managed by one team. So with the fixator on, because then team knew how to apply a circular external fixator and how to place wire, shan screw in
Sir,
case when
are you moving your slides or not? Because we are only seeing your 286 slide, number 286. Can you please press next?
Rizwan, I don't see press next here.
No, it's below the
Okay,
slide.
okay,
Oh,
right. So this was a just what I said, that there was skin defect as a result of rubber band treatment, and soon this patient was handed over to me after my arrival there in the field. We were lucky to land in a good hospital in Islamabad. So debridement, resection of bone left a composite defect, musculoskeletal defect. Uh, uh, about an inch of bone was resected, and because, as I said, that at our center, soft tissue and muscle defect, skin defects are managed by a one team, one person. So we know how to place our wires and chains so that they will not come in our way of raising a flap, local flap particularly, or in case a free flap is required. So we have a good access to the anastomotic area. So this is a flap which is based on one perforator of the posterior tibial artery, about 6-7 centimeter above the medial malleolus, and you can raise a huge flap on this single perforator. We do have a lot of patient with this flap and has published our cases also. So this was a huge flap raised on one perforator of the posterior tibial artery and rotated 180 degree to cover the defect. The donor site was skin grafted, and we do apply rubber band to decrease the area of requirement for the split thickness skin grafting, and this is healing of the skin graft well taken, as well as the result of the bone healing here. So as I said that our we have no idea about our stay in the area, so we did not offer him any lengthening about resection of this 1 inch of. So he was left with 1 inch of short extremity, and was advised that when the situation improves and healthcare conditions are good, so we can offer him lengthening, or somebody else in Islamabad or surrounding area can offer him lengthening if we need it. So yeah, this was our last encounter with the patient, and we have no idea what happened to him after this. This fixator was removed by our team, which was there in Islamabad for our follow-up patient. So that's all about this patient. So over to Rizwan, or should I continue to the next
should
case?
sir continue? We have got this is last case. Please continue. 5 minutes only.
Okay. So 40 years old young man presented to our emergency room with this blast injury uh, a high velocity blast and resulting in the crushing of skin all around the ankle, as well as the crushing of the bone just in the supramalleolar region. So on exploration, his all bone was free of the soft tissue and have to be removed as a result of debridement, and he was left with the defect. Though the skin was there was no skin defect at his presentation, but bone was all gone. This about 2 inch area above the, and he does have undisplaced talus fracture. So again, he has circular external fixator after a section of the bone. Talus was fixed with the few screws, and then an osteotomy was done in the upper part of the leg, and segment transport was effected. You can see the regenerate in the transported area, and this is a follow-up X-ray. The regenerate is consolidating. The ankle arthrodesis was achieved. Subtalar joint was functional. So this is a further follow-up of his healing. Yep, regenerate, and this is his clinical picture. All his skin has healed without any requirement of the skin work in the form of flap or skin grafts. This is his bony outcome, and this is his soft tissue outcome. I'm sorry I could not upload my functional videos for this patient, and this is his at about 3 years follow-up after his fixator was removed. So that was a salvage of quite severely injured injury with the help of dissection osteogenesis. So should I continue or stop? Dr. Rizwan? I'm sorry, I cannot hear you, Dr. Rizwan.
Continue, please. I will tell you when to stop.
Okay, thank you. So, this was a patient suffering from some bipolar disorder and presented to our emergency room after a fall from, I think, suicidal attempt, fall from height. So, the skin condition is visible in this photograph. I don't need to go into detail, and bone injury was severe crushing of the pilon here. And in addition to these injuries, he has a distal radius fracture, which was fixed by open adduction internal fixation. So, as soon as his general condition, systemic injuries were optimized, so this is the destruction frame we usually use in our periarticular fractures. So he was put on this frame, destruction, some preliminary destruction was applied to have some alignment of the pilon pieces, and then fixed with the circular external fixator. You can see this wire passing from medial malleolus to fix the fracture of the medial malleolus, and rest of the pieces were fixed utilizing multiple K wires in the just subarticular region. So subsequently his skin healed quickly. He does not have any deficit in the form of skin. His fixator was removed after bone healing, and this was another salvage of the extremity with the help of close reduction and external fixation with the circular external fixator. So thank you, Rizwan.
Thank you, sir.
I'm ready to answer any question.
Yeah. So just to, as we have got 4 minutes left, Dr. Tashfeen, how would you have managed or anything different which you want to do in any of the cases which Dr. Haroon showed, so that we could have something other than this thing? Would you kindly discuss?
Very complex and challenging cases. But Dr. Haroon has shown a very good method, and especially from the safety point of perspective, because these injuries really pose a lot of soft tissue challenges. If you do an open surgery, it is possible to fix everything anatomically by an open approach, but quite often the soft tissues don't uh, survive in these kind of injuries unless you've waited for 4 weeks, 8 weeks, and for everything to settle and then do the internal fixation. And by that time, things have started to heal. So I think I would also have chosen Elizarov as the main method for most of these cases.
Thank you. Dr. Sohail Muzammil, you have seen the three cases. Anything you want to add for the knowledge of the audience? Or
Well, given the nature of these injuries, I think we need a ninja master in Elizarov, like Dr. Haroon, because uh, without training, one cannot try and attempt Elizarov fixation. So I would say that better to refer these patients if we cannot do them, and refer them early so that somebody can take care of them. And that's the general idea.
great. I would totally agree that the Elizarov is not everybody's business and you need specialized training. Now, I would like Dr. Selene to kindly conclude our session, and we are very sorry for the first 15 minutes. Our opener batsmen were not playing well because of the internet issue. Sorry, sir.
Yeah, no worries. These things happen. That's what occurs when you have a live 24-hour around the world session. So I appreciate all of your guys' expertise and experience. Fantastic cases. All right, so we are going to start off at 12 a.m. New York City time in another minute. Make sure for all the attendees, you click on the next link in order to get to the next session. Our sessions are in blocks of 4 hours. So make sure you click in and we will start in a minute. Thanks, everybody.
Thank you, sir.
Thank you,
Thank
everybody.
you.